Our second speaker, a very eminent personality, pleasant face, smiley face, Professor Ali Zubairi. He did his graduation in 1992 and he worked in USA. He's a diplomat, American Board of Internal Medicine, Pulmonary and Critical Care. He is Professor of Medicine, Khan University, and has more than 100 publications with his name. He is running ILD clinic and pulmonary infection, and his director ILD program. I welcome Professor Ali Zubairi. Thanks.
Bismillahirrahmanirrahim. Assalamu alaikum, ladies and gentlemen. Thank you, Irfan, for a nice introduction, and thank you, PSIM, for giving me an opportunity to be a speaker here. I do not have any conflict of interest. COPD, as Dr. Professor Nadeem Rizvi said, that obstructive lung disease, including asthma and COPD, is the bread and butter practice of pulmonology. It is the third leading cause of death, and unfortunately, it is rising, especially in our part of the world and other low to middle income countries. What is COPD? The best definition comes by GOLD, which stands for Global Initiative for Obstructive Lung Disease. This is a program which was established in 1998 with the consultation of healthcare professionals and public health advisors, and this has been updated quite frequently. The first report came out in 2001, and the last report is in 2022. So they have defined COPD as it's a common, preventable, and treatable disease. It is preventable, and we'll see why. It is characterized by persistent respiratory symptoms, unlike asthma, in which you see intermittent symptoms, and airflow limitation that is usually progressive. Alveolar as well as airway abnormalities can be caused by significant exposure to the noxious particles or gases, and the main reason of COPD, as you all might be aware of, is cigarette smoke. Exacerbations and comorbidities contribute to overall severity in individual patients. So the burden of COPD, as you can see in this slide, is huge, significant. Cigarette smoking responsible for 80 to 90% of cases, third leading cause of death. More than 6.9 million people are suffering from COPD in Pakistan, and it affects more than 300 million people worldwide. So you can appreciate that the burden of COPD is significant. If you can recall from medical school, the word COPD was an umbrella term which was divided between chronic bronchitis and emphysema. I'm sorry that, there's iski wo thodi si out ho gayi hai. So the blue blotters versus pink puffers. But this classification is more or less obsolete now, what we call together now and lump together as COPD. Chronic bronchitis की pathophysiology में air tube narrowing होती है, lot of mucus production होता है, उसी की वजह से they bring up a lot of sputum, and it is because of the increase in size of mucosal glands and in the number of goblet cells, which causes ciliary damage and thickening of the muscles. In the emphysema, we know that there is an air exchange abnormalities because of the destruction of alveolar wall, which leads to loss of elastic recoil and eventually the destruction. So the diagnosis of COPD requires three things: risk factors, symptomatology, and then you confirm by spirometry. So risk factors of COPD, as I said earlier, that cigarette smoking is the most common cause, and that includes pipes, water pipes, shisha jisko kehte hain, uske alawa marijuana use, cigars, all these things are notorious and they can cause COPD. But another very important cause that is actually the most common cause in women, especially in this part of the world, is atmospheric air pollution. And as you can see in this slide, unfortunately, the two major cities of Pakistan, Karachi and Lahore, you can see the air pollution because of different reasons. And in the outskirts of both cities, one is from Lahore and the other one is from Karachi, you can see these atmospheric air pollution contributing. This is the neighboring India, New Delhi, and some other part of India. So COPD की atmospheric pollution जो है इस part of the world में is a very important risk factor. Symptomatology में I think all of you are aware of it, लेकिन एक symptom जिसको मैं emphasize करना चाहूँगा is excessive tiredness or fatigue. So if you see an elderly gentleman who is a smoker or ex-smoker is complaining of fatigue, think about COPD, because sometimes they not tell you that I have dyspnea, or they consider dyspnea as a part of aging process. So typical COPD का जो मरीज होता है हमारी setting में जाहिर है कि cigarette smoking is more common in males, so male gender, but don't forget that females can also develop COPD because of atmospheric pollution and the use of hookah in the villages and the rising trend of smoking in women, unfortunately, in this part of the world. Smoker or ex-smoker, dyspnea is the main symptom. They might have cough or sputum production. So think about COPD if you encounter a patient who comes with any of these symptoms and have exposure to risk factors. COPD is confirmed by spirometry. That's a standard test, which can be done in the office setting as well, but it is highly recommended that you do at least initial test in a PFT lab, in which you measure the forced vital capacity and forced expiratory volume in 1 second, and you calculate the ratio. So the post-bronchodilator ratio, if it is less than 0.70, it confirms the presence of airflow limitation. So spirometry should be highly considered to confirm your diagnosis and to assess the severity of airflow obstruction. And sometimes it is also helpful in the follow-up assessment, especially in making therapeutic decisions. COPD, this is a very important slide, and this is very important to educate your patient that it is crucial to quit smoking. I have seen that physicians don't spend enough time. If you spend even 30 seconds or 60 seconds, you know, कि आप smoking तो नहीं करते, आपको ये छोड़ना पड़ेगा. And be confident, you know. You have to tell them कि डॉक्टर साहब हम आहिस्ता आहिस्ता करके कम करेंगे. That doesn't work. You have to tell them कि अगर आप ये smoking की habit नहीं छोड़ेंगे तो ये दवाएं काम नहीं करेंगी. And as you can see in the slide कि regular smoker का fall in FEV1 after the age of 25 is much more rapid as compared to the person who has never smoked. We do know that FEV1 falls with the aging, but that is not significant enough to cause dyspnea. But in smokers, it is much more rapid decline in FEV1. कुछ और additional diagnostic tests जिसके बारे में आप सोच सकते हैं. Chest X-ray itself is not diagnostic for COPD, but it is helpful to diagnose other comorbidities, for example, concomitant interstitial lung disease or heart failure. Sometimes we recommend to get the full lung volumes and diffusing capacity अगर आपको concomitant diseases का clinical suspicion, or if you hear crackles, particularly coarse crackles or velcro type crackles जिसमें आपको interstitial lung disease का suspicion हो, along with COPD, and then other testing if as required. Severity of classification of airflow obstruction by the GOLD is on 4 grades. GOLD 1 is mild, in which FEV1 is more than 80% of the predicted value. GOLD 2 is moderate, which is FEV1 less than 80% but more than 50. GOLD 3 is FEV1 less than 50 but more than 30, and very severe is FEV1 less than 30% of the predicted value. And then there are other symptoms को score करने के लिए एक कहलाता है MMRC, Modified Medical Research Council Dyspnea Scale, जिसमें आप grading करते हैं just like New York Heart Association NYHA for CHF, जिसमें आप 5 grade लेते हैं from 0 to 4, depending at what point you develop breathlessness. I'm going to skip this, not going into the details because of the sake of time. जो इससे ज़्यादा useful जो tool है, that is called CAT, COPD assessment test, because it is not dependent on dyspnea alone. इसमें और भी symptoms को consider किया जाता है, जिसमें cough है, flame या sputum production है, chest tightness है, dyspnea है, activities at home है, जिसको ADLs कहते हैं. इसके अलावा sound, sleep है, and fatigue, जैसे मैंने आपसे कहा था कि that is something new which has been added recently by GOLD. This is a very important slide. GOLD highly recommends, especially for us, the pulmonologist, that you should use the ABCD assessment tool, जिसमें आप confirm करते हैं कि yes, this is COPD, post-bronchodilator ratio less than 0.7. You assess the airflow obstruction based on the GOLD criteria 1, 2, 3, 4, जो मैंने आपको बताए, and then you merge them together along with the exacerbation history and symptomatology. So symptomatology में you can either use MMRC or CAT score. अगर वो कैट स्कोर 10 से ऊपर जा रहा है तो वो बी एंड डी हो जाएगा, अगर वो कैट स्कोर कम है तो ए एंड सी हो जाएगा। इसी तरह एक्सेसरबेशन हिस्ट्री में आप पूछते हैं कि आप पिछले 1 साल में आप एडमिट तो नहीं हुए बिकॉज ऑफ सीओपीडी एक्सेसरबेशन, या आपकी आउट पेशेंट सेटिंग में एक्सेसरबेशन तो नहीं हुई है। तो इफ 0 or 1 not leading to hospital admission, this is A and B, and if it is more than 2 outpatient, or 1 or more than 1 leading to hospital admission, this is C and D. I know this is a little confusing, but it is very helpful for us. So consider 2 patients, both patients with FEV1 less than 30% of predicted value, both with CAT scores of 18, one with 0 exacerbation in the past year and the other with 3 exacerbations in the past year. तो दोनों को gold D according to the prior classification to hai, but with the new refined assessment scheme, the subject with 3 exacerbations in the past would be called gold grade 4 group D, and the other patient jisko exacerbation nahi hui hai, wo grade 4 to rahega because of the FEV1, but it will be group B. So this is important that treatment of stable COPD में आप symptoms को कम करने की कोशिश करते हैं और reduce the risk. So how we do that? I have highlighted in this slide that smoking cessation is the most important part, depending on their exposure to risk factors, and then there are other things mentioned over here. This is a whole list of inhalers and then the devices mentioned over here. I'm going to skip this slide because of the sake of time, but it has conveniently been divided into short-acting agents and long-acting agents, इसमें beta-2 agonist, anticholinergics, और आजकल जो हम use कर रहे हैं वो combined agents हैं, जिसके बारे में I'll briefly talk about it. And this is just a picture I took from the web of the different inhalers available in Pakistan. तो bronchodilators का जो rule है stable COPD में, याद रखिए कि LABA, long acting beta-2 agonist, and LAMAs, long acting muscarinic agents, are preferred over short acting agents, except for very mild disease जिसमें occasional dyspnea होता है, उसमें you can still use PRN medications as a short acting. Otherwise it is highly recommended that you pick either one of the two or combine them if the patients are progressive. Patient may be started on a single long acting bronchodilator therapy or dual long-acting bronchodilator therapy depending on the severity of the symptoms. Dr. Nadeem Rizvi ने only highlight कर चुके हैं कि inhaled bronchodilators are highly recommended over oral bronchodilators. So you have to educate the patient कि oral bronchodilators के side effects ज़्यादा होते हैं, ज़ाहिर उसकी absorption जो है वो systemic absorption होती है, तो उसमें आपको tremors भी ज़्यादा मिलेंगे, dryness भी ज़्यादा मिलेगी as compared to the inhaled form. Theophylline is not being recommended unless other long-term treatment bronchodilators are unavailable or unaffordable. For this part of the world, I would say that theophylline is still an option, but it is not a preferred option. So you can add on therapy में आप theophylline डाल सकते हैं, ensuring that the patient is using inhalers and is compliant and also the correct techniques. So that becomes very important. तो गोल्ड ने treatment of stable COPD के लिए जो group A है, which is the mild disease, उसमें उन्होंने कहा you can use bronchodilator of any type. They're not pushing you to use short acting versus long acting. So they have given you the option that you can use either short acting or long acting because the patient has mild symptoms. So you can use it on as needed basis, जिसको PRN basis कहते हैं. Group B के लिए Gold recommends that you should use a long-acting bronchodilator, जिसमें LABA or LAMA group B में has almost equivalent efficacy. LABA is long-acting beta-2 agonist and LAMA is long-acting muscarinic antagonist. Group C के लिए, the clinical trials have shown that LAMA is superior over LABA, but if the patient has exacerbations or progression of symptoms, you can add LABA. Or the second option is that you can add inhaled corticosteroid. We'll talk about it very briefly. I usually avoid inhaled corticosteroid initially in COPD treatment because of the potential risk of pneumonia, but sometimes you have to add it. And then group D, जो सबसे खराब ग्रुप है, जिसमें सिम्टम्स भी ज़्यादा हैं, प्रोग्रेशन भी है, तो उसमें you start with LAMA and then you add LABA plus LAMA, and then the third step you can add inhaled corticosteroid. और अगर उसके ऊपर भी patient control नहीं हो रहा, तो फिर दो नई चीज़ें in the last few years which has come up is a PDE4 inhibitor कहते हैं, phosphodiesterase 4 inhibitor, roflumilast, लेकिन इसका अपना क्राइटेरिया है कि पेशेंट का FEV1 लेस देन 50% प्रिडिक्टेड होना चाहिए एंड प्रीडोमिनेटली chronic bronchitis phenotype होनी चाहिए. And the second thing which has been on the horizon is the use of macrolide. I have honestly not used macrolide in any of my COPD patient because of the risk. खास तौर पे prolonged QT interval होता है, उसके अलावा जो है drug interactions होती हैं, and you see, you know, other side effects with the use of, and bacterial resistance, of course, because they get infectious exacerbations quite frequently. So, inhaled corticosteroid कब यूज करें COPD में? अगर पेशेंट लाबा और लाबा दोनों पे है और अभी भी exacerbations हो रही हैं या symptomatic है, yes, I do consider the addition of inhaled corticosteroids if they're having 2 or more than 2 moderate exacerbations or blood eosinophilia. So CBC, simple CBC is a very useful test. तो अगर more than 300 cells per microliters हैं या फिर उनको एक चीज होती है concomitant asthma, ACOS कहते हैं, asthma COPD overlap syndrome, then you can use it. जो 2 clinical trials in the last 2 years जो publish हुए हैं, one is called impact trial and the other one is ethos trial. इसमें they have compared the use of triple inhaler, जिसमें you combine LABA plus LAMA plus ICS versus LABA and LAMA, has shown that there was a trend in a decrease in mortality in the use of triple regimen in patients who have moderately severe to severe exacerbations. And then there was another study that was published in Respiratory Medicine, TRICOP study, जिसमें again show किया गया कि in patients who have moderate to severe COPD, they had improvement in lung function, symptom control, and significant reduction. Anti-inflammatory therapies में PDE4 के बारे में मैं आपको बता चुका कि it is added as one of the last resorts in a particular phenotype who is predominantly chronic bronchitis, very severe to severe COPD, history of exacerbations, long-term azithromycin की भी हम बात कर चुके हैं. एक चीज जो जनरल प्रैक्टिशनर्स बहुत कॉमनली यूज करते हैं वो म्यूकोलिटिक एजेंट्स हैं. ऑल्दो gold has not is not against the use of it. It is helpful in patients who have a lot of sputum production, or you know, it is sometimes difficult to expectorate because of different reasons. Yes, you can add it, but it is not the treatment of choice. So I'm going to skip this. एंटीटसिव्स का कोई रोल नहीं है. डॉक्टर नदीम रिजवी से पिछली टॉक में किसी ने पूछा था. एक और बहुत कॉमन चीज जो हमारे यहाँ इंटरनल मेडिसिन एंड जनरल प्रैक्टिशनर्स यूज करते हैं कि अगर साथ में पल्मोनरी हाइपरटेंशन है, दे ऐड सिल्डेनाफिल. So there is no proven role of sildenafil in the treatment of COPD associated pulmonary hypertension. जो sildenafil approved है वो group 1 pulmonary hypertension के लिए, and there's some data on group 2. So group 1 को पहले idiopathic कहते थे, unknown cause, and the group 2 is mainly due to the left heart disease. So these are the only 2 indications of the use of bosentan and sildenafil. Otherwise, you know, there's no proven role in COPD associated. Biological agents का के ऊपर कुछ trials हुए हैं, लेकिन ये कि that has also not been statistically significant. Oxygen use has been recommended in patients who have resting arterial hypoxemia, which is defined as the PaO2 less than 55 millimeter of mercury, or SpO2 less than 88, or PaO2 more than 55 but less than 60 with erythrocytosis or right heart failure. And then there are a couple of surgical options that I'm going to skip it, that you can sometimes refer your patients who can tolerate the surgical procedures. So acute exacerbation, I just take 2 minutes. Acute COPD exacerbation is an acute worsening of respiratory symptoms that result in additional therapy that is classified according to the treatment regimen that you give, and you can just Google it. The Rome definition that has been published in 2021 for the acute exacerbations is the most common one. Non-invasive ventilation के लिए indication is respiratory acidosis or clinical worsening which is not responding to continuous bronchodilator therapy and persistent hypoxemia. And if they are unable to tolerate non-invasive ventilation, yes, you have to put them on invasive mechanical ventilation. And there's a lot of data कि आप 1 या 2 दिन rest करके on invasive mechanical ventilation, you can extubate them to BiPAP. Vaccination, influenza vaccination is highly recommended. SARS-CoV-2, you know, recently we had a pandemic. So that vaccination, pneumococcal vaccination, and the GOLD also recommends using vaccine against whooping cough and zoster vaccine. Comorbidities are common in COPD. COPD is now a disease. It's not only a respiratory disease, but it's a generalized disease. Here you can see the picture of the overlap syndromes. जो मैं आपको बता रहा था. You can see pulmonary fibrosis. You can see obstructive sleep apnea. And you can see asthma COPD in combination. And don't forget that the lung cancer is one of the common cause of death in patients with COPD. So if your patient is 50 to 80 years old and who is a current smoker and 20-pack year history of smoking, it is highly recommended that you should go for low-dose CT scanning because chest X-ray is not very sensitive. So this is one of my last slide, that summarizes. We do celebrate World COPD Day. November is the awareness month of COPD. We hold seminars and other activities to create awareness. Don't forget, smoking cessation is very important piece. And then, of course, medication adherence, teaching of the proper use of inhalers, all these things are extremely important. So thank you very much for your attention. I would appreciate if Dr. Irfan kahan gaye? If he can allow, take one or two questions. Oh, he's here. I'm sorry. He's too fast.
Sir has to go, so if you want to ask any question, you're more than welcome. COPD, third leading cause of death. No question.